There are some specialties that are just very specific and focused on particular populations. And one of those is obstetrics and gynecology, often called OB-GYN, OB-GYN, OB-GYN. I call it OB-GYN. I don't know. I don't know what the right thing is to say, but I've always called it OB-GYN, so I'll be referring to it that way throughout the video. Someone once told me in medicine, if you don't know how to pronounce something, just say it loud and proud, and then everybody else will doubt whether they're saying it right. Now, this technically is two different specialties, obstetrics and gynecology, but it's so often lumped together that we're going to talk about it as one entity. Anyway, I am joined today by a PA who has worked in OB-GYN for most of her career, and she is also president of the Association of Physician Associates in Obstetrics and Gynecology. She really knows her stuff and really knows this specialty well. She's going to be telling us all about kind of the ins and outs of the specialty, things she likes and dislikes about it. And we're going to talk about all the other regular stuff, like what procedures you can do, the typical hours worked, and how many patients you usually see in a day. So if you're interested, want to know if this specialty is right for you, or just wondering kind of what it's all about, then stay tuned. Just want to say thank you so much to all of my subscribers and people who leave me comments and who are supporting this channel. It means a lot to me. So help me welcome Melissa Rodriguez, our special guest today.
Hi, my name is Melissa Rodriguez. I've been an OBGYN PA for 12 years now.
Thanks for joining us, Melissa.
Thank you.
So you have a fairly long career. Has it all been working in OB-GYN?
The vast majority has been in OBGYN. I did have a brief stint in radiation oncology for breast cancer.
What are you currently working in right now?
So I just transitioned to a new position, and it's the Women's Health Emergency Department, which has been a great experience because we see obstetric patients in labor, but we also see non-pregnant patients for a variety of issues. We've even had male patients come in because it's considered an emergency department. So if it's closest, then that's where they bring them.
So it's a whole emergency department just kind of for women's health?
Yep.
Oh, wow. I never heard of that. Do you think that's fairly new, or have you heard of those around the country?
It's a new concept, but it definitely is unique. We have OB-EDs around, that are popping up, but this one is unique in the sense that we see a variety of patients. I've had an appendicitis and even a Narcan patient.
Oh, wow. Cool. That sounds cool for somebody who really likes OB-GYN, but then they want to have a little mixture of things.
Absolutely. It's a great concept.
Since we're talking about patient populations, I assume like in a regular outpatient clinic in obstetrics and gynecology, you are, working with women mostly in their reproductive ages. Are there any surprises, or is it pretty much exactly what you think?
It depends. I have seen anywhere from 11 years old all the way until 90. We don't usually see the children because they do go to the pediatrics.
Yeah, I was wondering about that. Like if somebody was interested in working specifically pediatric OB-GYN, there are positions in that specialty as well.
Yeah, absolutely.
Are most of the outpatient practices a mixture of obstetrics and gynecology, or are there lots of different clinics that are just gynecology and some that are just obstetrics?
My experience has been both OB and GYN together, and it makes a great variety. But I've had practices where I've worked and it's been only obstetrics and high risk obstetrics, and there's people that only see GYN patients because of the malpractice and everything.
So that's interesting. So even within a practice, even if the practice itself sees obstetrics and gynecology, some providers, specialize, only see gynecology or only see obstetrics.
If they choose, yeah.
So we talked about outpatient. What about inpatient? Do you know of roles that are strictly inpatient for PAs and NPs working in OB-GYN?
I know for PAs, that's all I did in the beginning of my career. It was strictly inpatient, labor and delivery, where we covered, laboring patients, the triage postpartum, and then also GYN service. NPs, in my experience, did not work on labor and delivery. They have privileges up until, patient is in active labor.
Yeah, that's a question that I see asked all the time. People who are looking to become a PA one day, but they're like, oh, I really want to deliver babies, or even PAs that have gone through training and have delivered babies themselves still don't know if we can deliver babies or if PAs do that in labor and delivery. So let's talk about that a little bit more. Can you tell us what you've seen in your experiences and what you know of around the country?
It's funny because I love delivering babies. We've always delivered babies since the start of my career. And it's a great experience. But it wasn't until probably 5 years in that I realized that the whole country wasn't doing this. And it's in New York City, it's very prevalent. There's a lot, every single hospital there, at least the large academic centers, have PAs staffed on labor and delivery. So it's commonplace. But I kept getting emails from around the country saying, hey, can we do this? And I'm like, of course, I do this all the time. So that's where it became my biggest, passion to kind of fix that. But definitely it's with hospital systems. There's no laws or anything that says that PAs can't do this. Most laws say that we have the same scope of practice as our collaborating physician. And so there should be no issue, but it's more at the hospital level.
Now, NPs, though, to your knowledge, I know you're not an NP, but does their license not allow them to deliver? They have to become a certified nurse midwife, right, if they want to actually deliver.
Correct. Their training is up until the latent labor. So after that, then they cannot manage anymore.
And so up in New York, where it was very common for PAs to be in labor and delivery, were there lots of certified nurse midwives working up there as well? Was there a combination, or was it almost exclusively PAs?
I wouldn't say a lot. There's some hospitals. I did have one hospital that had a robust midwifery service, and they were fantastic. But in the other hospitals, not really. I don't know. I know that they had it historically, but not while we were there.
So just to clarify for people watching who may not understand or might have missed that, PAs are all trained to deliver babies and can absolutely work in labor and delivery per our license and per our scope of practice. But it's really just kind of what comes down to common practice is what you're saying, right? It's what these hospital systems have decided on and who they're going to hire. So that's good news, I guess, in a way, if people are really interested in it, to either scope out those medical systems and hospitals that allow it, but also to talk to their own hospital system.
When people reach out to me, that's what I say. You're in the hospital system, go to the OBGYN department, speak to the chairs, speak to the administrators, because we are trained for this. We have a whole curriculum based on this. It's part of our ARC-PA and PAEA requirements. We get tested on NCCPA on this information. And so just highlighting that we are medically trained and we can assist in many of the conditions, not just the low risk patients, but the high risk as well.
Yeah, and because that's an important distinction. Certified nurse midwives, they can deliver, but they have restrictions, and they don't have like full prescriptive authority, right? If I remember right, and there's certain cases that they can't, right? Are they only for the more straightforward deliveries?
Absolutely. They are full term, so 37 weeks and beyond, and very low risk, no other complications, where they can deliver or provide care autonomously. If they have a collaborating physician, then they can, co-manage a patient with a higher risk. But they typically, do not see twins. They do not, if they've had a previous C-section, they wouldn't do a trial of labor after a C-section. And so there's a number of conditions where they would have to hands off care.
And so as a PA who's very experienced in labor and delivery, you are the sole provider, like you don't have a physician in the room with you when you're delivering, correct?
It depends on hospital policy. Really, it comes down to privileges. If in the privilege it says there should be a physician in the hospital somewhere, then that's the case. If they say they want somebody in the room, I know in the beginning when I first started delivering, I always had a physician right nearby, and then afterwards it was like, where? But it's really most deliveries, thank God, are low risk, and they go pretty smoothly. So I think that our expertise comes from the emergencies, right? When we have to deal with those complications. So after a few of those, you feel confident.
That's a good point, an important point that people need to remember if they're going to go talk to their department and talk about, wanting to move into the labor and delivery, is that we have the training and we can do things that the certified nurse midwives can't. And I'm not saying anything bad about them. They do amazing work and they have, their training, but our training is actually more broad because we can handle all of the other things that come along with it.
Yeah, and that's my biggest thing. When I see when I see reports about these maternity care deserts around the country, right? Half of the country does not have care, and there was always a push for midwives, which is fantastic. There's about 9 to 11,000 in the country, and so there's much more than we have. But have they considered PAs, right? Because there's so many, the maternal mortality rate is increasing so much. And it's medical conditions that they're dying from, right? There's the cardiomyopathies. There's, I can, name a few, but a lot of them are medical conditions where we can come in and say, hey, we've been trained in this, we've been educated, we are, we've retested it frequently. So that's my real big issue. Like I just don't see, I'm like, we can help, and this is where we need to be.
When you work in kind of a regular outpatient OB/GYN clinic, what are the typical hours, in general? I know everything is different, but what are some typical hours and kind of how many patients are you usually seeing during the day?
So in my outpatient experience, I did pretty much a 9 to 5, Monday through Friday. I would see anywhere from about 10 patients sometimes on a very light day to 30 patients on a very busy day. So it was quite varied and it was a mixture of OB and GYN patients. I did a lot of procedures. In my practice in particular, the nurse practitioner who was also employed didn't like procedures. And so everything would refer to me. So I would have a mixture, I would do colposcopies and endometrial biopsies and IUD placements and insertions and Nexplanon. So the day was a lot of fun for the most part. And then, of course, we had a lot of education. I love the counseling part of obstetrics and also in gynecology. So it was a busy day, but definitely fulfilling.
When we talk about procedures, you mentioned, quite a few of them there. Are there other procedures that PAs with more training, like specialty training, can do, PAs or NPs?
Yeah, I think, if you wanted to do in the office procedures like hysteroscopy, you can be trained in that. You can also do LEAP procedures to take out the outside of the cervix for any cancer patients or at risk for cancer. That's something that I was not trained in, and my docs did not feel comfortable with doing in the office, so we didn't. But yeah, absolutely. If you work in a place like that, you can.
So what about like gynecological surgery? Is that something that often outpatient clinics, the physicians will do, like they'll have a day where they do surgeries as a PA you can go assist, or is it usually separated? If a physician is going to be an OB/GYN surgical physician, and that's pretty much all they do. How is that divided up?
It's very dependent on the hospital system. Some can just be inpatient and do surgeries all day. Most of the time, they have to have a clinic base where they can have patients. In my experience, I had my own panel of patients, and so even though my surgeons they had their own surgery scheduled days, it wouldn't be profitable for me to also be there as a first assist. So I continued seeing patients. That being said, I had another colleague that wasn't part of my practice who is minimally invasive gynecology. So I did first assist with him in robotic cases often. So I got my fix for surgery, but in a different practice.
And is there much call going on in OB/GYN? I mean, I guess if you're in labor delivery, are you pretty much on call all the time?
Well, for me, when I worked labor and delivery, I was a hospitalist. So, as a laborist, for instance, I was just there when I had to be, and when I wasn't, I was off. So, it was fantastic. When I was outpatient, I did not have to take any call. So, not really in my experience, but yeah, absolutely. If you are the delivering provider and they're delivering in the middle of the night, then you have to go in.
What things about OB/GYN has been kind of a surprise for you?
I guess, as a student, I felt like everything was set in stone, right? Everything was perfect, and I just had to learn how to do that. And what I've learned over the years is that rules change and practices change, and everything kind of we learn as we go, even as a professional. So just keeping abreast on new recommendations and making sure we're providing the best care.
So, what are the things that you really love about OB/GYN?
I really love counseling and guiding patients through their normal physiology and how they can improve things. That's the best part because you're not taught as a child, oh hey, you're going to have this menstrual cycle problem, or once you're pregnant, what do you do? There's always this gray area until you're 8 weeks and you come into the office. And then of course delivering babies and helping a first time mom get through the laboring process successfully and then finally have her reward her baby, then that's amazing.
So what about the flip side? What are the worst things about the specialty? Either just things that are personally hard for you or things just in general that people might find challenging about the specialty?
Fresh in the mind is just this morning when we had a 39-week patient come in for contractions and there was no fetal heartbeat. And and it was her first baby, and that never gets easy ever in my entire career. It even when it's a miscarriage in the beginning, that's tough, but these are just hardest part, and being able to walk them through it and help them grieve, it's rewarding to be able to be there for them with experience and compassion, but always tough.
What about on the gynecology side?
Yeah, I can say that ovarian cancer is the worst. I feel like every patient that I have experienced with ovarian cancer, it's always stage four, stage three, stage four. And at that point, there's not much option that we have. So that's my toughest one. I think that if it's, endometrial cancer, we'll take out the uterus. If it's breast cancer, well, there's always something we can do. But once you're at stage four ovarian cancer, it's hard.
In general, where do you think OB/GYN falls for salary range? Well, first of all, do people mainly work salary or is it common to be paid with RVUs in OB/GYN?
I think it's depending on the practice. When I worked outpatient, I did, have my RVUs that were being billed and I could see the profit, but I was paid salary. And we got a bonus if you reached a certain mark on quality and everything. So that was good. Most of the time, like right now, I work hourly. So while I was inpatient, it was hourly.
For pay, like does it tend to be like kind of a mid-range specialty or does it tend to be lower like primary care and pediatrics or does it tend to be a little bit higher?
In general, I think that it's in the mid-range. Yeah, I when I first started, I remember they said that we're at the lower range, but it wasn't my experience.
I've always heard that the obstetric side for malpractice is something that physicians have to pay a lot extra on their malpractice insurance. Now, most of the time, the malpractice insurance is covered, but is there anything that people need to think about or consider on the malpractice side if they're thinking about going into OB/GYN?
Yeah, so the CMNF, that's the company that actually provides malpractice for PAs. They are amazing and it's not so expensive. So to get a secondary insurance is always a good idea. And they also, I've touched base with them before and they said, PAs delivering, absolutely we cover that. So it's a good resource for sure.
It's just such an emotional thing if things go wrong with their baby. So, is it a very I guess what I'm trying to get to, is it a very litigious specialty to work in?
I've heard physicians say that you're going to get sued at some point in your career. Like that's the standard. It is very difficult because we try as best we can to change practices, prenatally, or even make sure that things go smoothly in the hospital. But not every baby is going to come out perfect, and so that's the expectation. So of course, they're upset, understandably so. But I think that the way that courts have rules has set the precedent. So it makes providers scared to practice in it, right? Because you can lose everything. So this is why we have a shortage in OBGYNs.
And why you recommended getting supplementary insurance, I assume.
Yes.
What personalities do you think do well in OB/GYN?
Oh, those go-getters, you have to keep going. One thing that I always say is that my colleagues are always the ones that are like, I'll do it, open to learning, open to seeing patients and not just like, oh, I've done enough for today. You have to be motivated and always seeking, the best possible care.
So how did you find your first position? Because you worked OB/GYN straight out of school, right?
I was told that it would be hard to get a position in OBGYN. So I started looking early, and about February, there was a posting. And so I applied for it and I went and I had the interview as I was still in PA school when I was interviewing, and I got the job and it was a great experience. And they waited until August. Remember, this is February till August for me to start.
If somebody really knows that OB/GYN is what they want to work, do you think it's fine for new grads to come out and go straight into that? Or if you had to do it again, would you maybe do some family practice or anything first?
I know. I think it's better to just go straight into it. If you love a specialty and you know that's what you want to do, then you're going to prepare effectively for that new job. And so I don't think that being in family medicine will add anything to it.
And so, for those who are still in school and who know that they want to head towards OB-GYN, in addition to having a specific rotation in that, what other rotations might be helpful?
I found it really helpful to actually go into maternal fetal medicine. Um, I worked 2 years on labor and delivery and then went to maternal fetal medicine, and my world exploded with information. So I think if, as a student, if you were able to have one of those rotations and kind of see all the high risk conditions and the ultrasounds, that would be beneficial.
Could you talk about that subspecialty a little bit more?
Yeah, it's solely dedicated to obstetrics. And so it's more of the high risk conditions. And so if you have chronic hypertension or asthma or thyroid disease, whichever medical condition you have, then that's who you will be seeing in pregnancy. And they also specialize in doing ultrasound. So if you have like an anatomy scan at 20 weeks where they do the full fetal survey, then it's usually a maternal fetal medicine physician who's reading that ultrasound. So as a specialty outpatient, you would have consultations in the office to kind of learn more about the disease and what you can do. I worked inpatient with it. And so in that, it's more of, patients that's so sick that they have to come in to be kept in the hospital, observed and treated in that sense. So definitely a broad subspecialty, but very important.
Okay, so say somebody is just coming out of school or they've been working in another specialty and they really think they want to move into OB-GYN. What kind of resources would you point people to, or any tips on how to get yourself prepared to be a good candidate to work in that specialty?
The Association for PAs and OBGYN has a resource page where we list a number of things. There's guides to that new onboarding, time to go into OBGYN and what you should focus on. There's even a manual to kind of help PAs get into the specialty. That being said, the American College of Obstetrics and Gynecology puts out practice bulletins on different conditions. And so having access to that, where the APAOG, or the Association of PAs and OBGYN, provides a discounted membership rate, they have all the practice bulletins. So being familiar with what the current standard of care is a great way to prepare for the specialty. And I'm an old school, nerdy PA. I have textbooks that I love. And so making sure that you know Williams Obstetrics and Williams Gynecology and all the other ones, it's important because that's where you get your foundation.
And as we mentioned earlier, you are president of the Association of Physician Associates in Obstetrics and Gynecology, right?
Yeah, that's correct. It's been a lot of fun serving as president.
So they have officially changed the name over on everything, right? To
We
associates.
did. Well, we did the articles of incorporation. And so we're waiting for our next tax season to change it through the IRS. It's a process that AAPA is guiding us on.
So is there anything else that we haven't really talked about that you would like to bring up or talk about?
Yeah, so the current landscape of reproductive care and the limitations it's a huge problem in our specialty at the moment. Despite, how people feel about the surgical procedure, what we're seeing is that it's a violence against women and restricting women in what they can do, right? There's a privacy issue that is at hand. There is no reason why legislation should be anywhere near a patient's bedside. And so it's a big issue. We at APAOG have created a task force to help address this issue in the PA level. And we are working closely also with the physician societies, and even the nurse practitioner societies have reached out for support. So we're trying to make sure that we stand by our mission as PAs to increase access to care and to provide the best care we can provide.
So I don't know if Texas is unique in this, but I know the law that Texas passed, you can be charged as a provider for even talking to a patient about abortions or abortion services that may be available to them, not doing it, but just talking about it. Are you aware of that in any other state?
Oklahoma, Ohio, all this. Yeah, definitely it's challenging times, and it's really unethical, in my opinion, to withhold information from patients. It's like a life-saving medication. I won't tell you because my legislator says I cannot, and it's really unfortunate, but it's going on. And so hopefully we can band together and improve reproductive access and also keep legislators out of the patient-provider relationship.
Thank you so much, Melissa. I'm excited for you in your new position, and I wish you all the best of luck.
Thank you so much for having me. I hope more people go into this specialty, and I'm here to advocate for everyone.
Great stuff from Melissa, and hope that that gave you a better understanding of what it's like to work in obstetrics and gynecology. One of the things I love most about this interview is touching on that topic of PAs working in labor and delivery. There's absolutely no reason why we should not be highly represented in that area. So if you work in a hospital or a medical group that does not allow PAs to participate in labor and delivery, I would urge you to go talk to them, educate them on the training that we receive, and remind them that our scope of practice is broad. So if we have the training and the scope of practice, why aren't we being utilized? And also, of course, the legislation, the overturning of Roe v. Wade, and how it affects medicine. No matter what your personal beliefs are, you should be appalled that providers can actually face charges for even talking to a patient about a medical procedure or something that can save their lives or significantly alter their lives. If you have some comment that you'd like to add about this video, either your experiences or advocating for one thing or another, then put it down below in the comment section. If you want to see more videos of PAs and NPs working in different specialties, you can watch these videos here. And you can also go to my main channel page to watch videos about PAs and NPs doing cool and unusual jobs, working in non-clinical jobs, and entrepreneurial ideas for those of you who want to start your own business. Thanks for joining me today. Take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.